Good morning, everyone. My name is Jordan Morris, and now we will be presenting the NHSN annual training series on laboratory ID event surveillance on multidrug-resistant organisms and Clostridioides difficile infections. So welcome, and let's get started. Here's a couple of housekeeping notes. This call is being recorded. Please use the chat box for questions. Today, we'll review multidrug-resistant organisms and CDI reporting requirements, summary data, LabID event definitions for methicillin-resistant Staphylococcus aureus and Clostridioides difficile, as well as a couple of frequently asked questions which will be basically scenarios where I ask questions and you give answers, and we just talk about those answers, and then I'll give a couple of resources that you can use. And all of this information will be coming from Chapter 12 of the Patient Safety Manual. So let's get started. These are the current reporting requirements for MDROs and CDIs. Since MDRO and C. diff pathogens may require specialized monitoring to evaluate if intensified infection control efforts are required to reduce the occurrence of these organisms and related infections, there are a few options to report them. The first option is core reporting, which offers two independent reporting methods: proxy infection measures, which focus on laboratory-based reporting, and infection surveillance, which focuses on infection criteria-based surveillance reporting. Now, once you have chosen your core, you may choose either one or both, and then may also choose to engage in supplemental reporting, which we will talk about later. Now we will go more in depth on the core reporting. The LabID event reporting option allows laboratory testing data to be used without clinical evaluation of the patient and is therefore a much less labor-intensive method to track MDROs and CDIs. LabID event reporting is only for collecting and tracking positive laboratory results that are collected for clinical purposes. Infection surveillance enables users to utilize the NHSN HAI definitions to identify and report infections associated with MDROs and or C. diff. Now we will talk about the other type of reporting, which is supplemental, which is optional. There are two methods of under supplemental, which is prevention process measures, which allows facilities to monitor adherence to specific prevention measures. And then the other method is active surveillance testing. This allows facilities to use results to monitor the AST results to monitor the prevalent and incident rates of MRSA and or vancomycin-resistant enterococcus colonization or infection. This information will assist facilities in assessing the impact of intervention programs on MRSA or VRE transmission.
The table summarizes the reporting methods available for each organism category. Depending on the organism, facilities may report using methods A, B, C, or D, while some supplemental reporting options are not applicable to certain organism types.
Now, we will discuss what each reporting method symbolizes. For A, facility-wide by location, it reports for each location separately and cover all locations in the facility. For method B, selected location within the facility, it reports separately for one or more specific locations within the facility. This includes reporting individual events and denominator data for each of the selected locations. For method C, overall facility-wide, there are two options for this. Overall facility-wide inpatient or FAC-YN, which is used to cover all inpatient locations where denominator data are collected When using FACYN reporting, facilities must also include location-specific reporting for outpatient emergency department in 24-hour observation locations. For option 2 under overall facility-wide, this is overall facility-wide outpatient or FAC-wide out. And it is used to cover all outpatient locations affiliated with the facility where encounters are captured. Facilities must choose to monitor FAC-wide out in addition to FAC-wide in. Finally, option D is similar to option C, but it focuses on blood specimens only. This method is available for MDRO LabID events only and targets the most invasive events. Report individual LabID events from each inpatient location and total denominator counts for the entire facility. So now we will discuss MDRO reporting requirements. NHSN MDRO LabID event reporting is only required for MRSA and NHSN. However, other pathogens can be monitored in NHSN, such as methicillin-susceptible Staph aureus, vancomycin-resistant enterococci, cephalosporin-resistant Klebsiella, carbapenem-resistant Enterobacter species, multidrug-resistant Acinetobacter. And definition for these pathogens can be found in the Chapter 12 of the Patient Safety Manual. Well, now reportable in NHSN, CRE, carbapenemase producing crab, carbapenemase producing carpa, and Candida auris are reportable diseases or conditions in Tennessee that are required reporting by all labs located in Tennessee, as well as those who test Tennessee residents. So this slide this talks about MRSA reporting requirements for Tennessee facilities. So if you are, if your facility type is any of these list of facility or hospital types, you are required to report MRSA bacteremia LabID events. Similar to the previous slide, if your facility is a type of a facility that you see listed here, you are required to report CDI LabID events.
The facility types included in this reporting guidance are acute care hospitals using facility-wide inpatient or FAC-wide in, includes emergency departments, 24-hour observation locations, CMS certified inpatient rehabilitation facility units within the hospital, also including long-term acute care hospitals or LTACs, inpatient rehabilitation facility, freestanding, also used in facility-wide inpatient FAC-wide in.
All right, so let's discuss 2026 changes. So the new language just provide new content describing available descriptive analysis reports and how they may be used for MDRO and CDI surveillance. It also expanded data analysis section to explicitly include use of the 2022 NHSN baseline. For the LabID event time frame 14-day rule, it clarified language that states that the 14-day time frame applies between positive specimens collected in the same location, not 14 days between reported events. And a last clarification, it just talks about the multi-step testing interpretations, which added more detailed examples and explanatory text to improve consistency in LabID event determination. Now we will move on to the looking at MRSA and CDI data. So there are two types of data types for LabID events. There's the numerated data that is reported using the laboratory identified MDRO and CDI event form, and the nominated data, which uses patient days and admissions and encounters, are reported using the MDRO and CDI monthly denominated form. As a reminder, to report your numerator and denominator data, your facility should have mapped every inpatient location, outpatient ED, and 24-hour observation location, as well as include facility-wide ED and 24-hour observation reporting of MRSA, bacteremia, and C. diff LabID events in your monthly reporting plans. So let's talk about numerated data. This is what it looks like in NHSN. And to report numerated data each month, facilities should use the protocol, the LabID event protocol, to identify MRSA and C. diff LabID events. You would go to event, add event, which is all on the NHSN website once you log into the NHSN site. And then you would go to all identified, you would be able to look at the LabID event after clicking on event from the previous slide. So you will not be able to use the fact-wide N location when reporting individual LabID event. Fact-wide N is the location used for reporting denominator data, not numerator. To access the MDRO denominator form, log into the NHSN application. On the blue menu taskbar, select Summary Data tab and then Add. On the next page, it will offer you options for the summary data type. Select MDRO and CDI denominator form, all locations, and then select Continue. So NHSN, so then you would select location code, month, and then the year. NHSN uses a single facility-wide inpatient denominator that includes every active map inpatient location within the hospital for LabID reporting. All eligible and active inpatient locations are grouped to a non-physical location, fact-wide N. SIRS are only able to be calculated for the fact-wide N and cannot be generated for unit-specific locations. This is the location that should be selected on your adjacent monthly reporting plan and will be selected from a drop-down box for location code, and then you would select the month and the year. The summary record contains a count of all patients who were admitted to an inpatient unit in your healthcare facility throughout the reporting month. This information is used to help generate your facility's rates and SIRS for LabID reporting. The numbered rows must be completed to save the form successfully. Formulas have been added to rows 2 and 3, instructions so users can see how to calculate the correct patient days and admissions on these rows. Row 1 is the total number of patient days and admissions from all active inpatient locations from your facility. This excludes outpatient location totals from these fields. In this example, we have 203 patient days and a total admissions of 151. Row 2 is a subset of row 1 and represents the total number of patient days and admissions of all active inpatient units with the exception of CMS certified rehab units and CMS certified psych units. These two units had 63 patient days and 66 admissions, which is subtracted. The total entered in row 2 will be 140 patient days and 85 admissions. Row 3 is a subset of row 1 and 2 and represents the total number of patient days and admissions of all active inpatient units with the exception of CMS certified rehab units and CMS certified psych units, as well as the NICU and well baby units are subtracted from the totals found on row 1, and new totals will be entered in row 3. The NICU and the well baby units had 52 patient days and 18 admissions, and these are subtracted from row 2. The total entered in row 3 would be 88 patient days and 67 admissions. Fact-wide and denominator summary field for CDI test type has been modified to request the standard CDI test method. The response for the standard test type or algorithm used to identify CDI should reflect the testing method standardly performed by the testing laboratory for the quarter. The standard test type is reported on the FACT-YN and CMS certified IRF unit denominator forms on the third month of each quarter: March, June, September, and December. For CDI, the primary test method is recorded in the summary data. The CDI test type is collected only on the third month of each quarter, like I said earlier. And then the primary CDI test method is the test type used most often by your facility laboratory, greater than 50% of the time. Without indicating the test type, a CERN will not be generated for the quarter. Our drop-down box is available on appropriate months and provides the common methods used for CDI testing. Please do not select other if possible. The list of test types are regularly updated and should cover the majority of tests. If your test is not listed, please email NHSN for assistance. For emergency departments and dedicated observation units, monthly denominators are entered as total patient encounters each month. As a reminder, there are no exclusions by age for outpatients.
For FACT-wide out locations, emergency departments, dedicated observation units, and other outpatient units, denominator data are reported as total patient encounters each month. There are no age exclusions for outpatient encounters.
When determining patient days, a dedicated observation unit is considered outpatient, so it does not contribute to any inpatient counts. Admissions to such outpatient units represent encounters and are reported for the observation location. An observation patient housed in an inpatient location should be included in any appropriate patient or device day counts for that inpatient location. So what do you report if you have no LabID events? If you have no LabID for the month, you would check report no events. Or you will get an alert that says incomplete summary data. If you do not enter an event after checking the report no events box, the system will uncheck the box. As a reminder, CDC will not send data to CMS unless the data is listed in your monthly plan. Now, let's discuss NHSN definitions for LabID events. To meet the eligibility criteria of Mercer, the organism identified must be a Staphylococcus aureus specimen obtained for clinical decision-making that tests oxacillin and cefoxitin or methicillin resistant by standard susceptibility testing methods, or any laboratory finding of Mercer. a CDI positive laboratory assay is a positive laboratory test result for C. diff, toxin A, and N or B, and it's tested on unformed stool specimen. Or it's a toxin-producing C. diff organism detected by culture or other laboratory means performed on an unformed stool. So how do you record a LabID event if your facility uses multi-step testing? When using a multi-step testing algorithm for CDI on the same unformed stool specimen, the result of the last test performed on the specimen that is documented in the patient medical record will determine if the CDI positive laboratory assay definition is met. So prior positives are not considered. So just pay attention to the last performed laboratory assay. For example, A, your first test is negative, second test is positive, and third test is positive. So your documented results will be positive. So it is an eligible LabID event. For example, B, your first test is positive, second test is positive, and third test is negative. So your documented result will be negative. So this will not be an eligible LabID event. And I want you to take a look at these examples because this will also be on the case-based. This will possibly be on the case-based training in the month of March. Well, that will be given in the month of March. So the NHSN SIR risk adjustment is based on final test in the algorithm.
Example C results in a positive final documented test result and will be considered an eligible LabID event. Example D results in a negative final documented test result and would not be considered an eligible LabID event.
If facilities elect to report additional MDROs besides MRSA and CDI, NHSN definitions, these pathogens can be found in Chapter 12. If facilities choose to report, they must indicate each reporting choice chosen for the calendar month on the patient safety monthly reporting plan. The 24-hour dedicated observation unit has to be mapped as an observation unit for it to be considered outpatient. If your patient is in observation status but in an inpatient location, they will be considered and recorded as inpatient. Specimens collected in emergency department in ED or 24-hour observation locations are only entered once assigned as outpatient. Specimens collected from other affiliated outpatient locations should be reported to an inpatient location if collected on the same calendar day as inpatient admissions. When a patient goes to a clinic, obtains a specimen, and it is positive, the physician admits them to the hospital, which will be reported as an event to the inpatient location. The affiliated outpatient location would need to share the same patient identification system as the admitting facility, and it needs to be a part of your healthcare system. So now we will discuss LabID event categorization. So this base definitions apply to all LabID events. A specimen is considered a community onset if the specimen was collected in an outpatient location in which the patient was not previously discharged from an inpatient location within the same facility less than or equal to 28 days prior to current date of specimen collection, or collected in an inpatient location less than or equal to 3 days after admissions to the facility. Just to be specific, days 1 through 3. A LabID is considered a healthcare facility onset if the specimen was collected more than 3 calendar days after admissions to the facility. So on or after day 4. So this flow chart shows that if a patient stays in the hospital for 1 to 3 days, it is considered community onset. But if the patient stays 4 or more days, it is considered healthcare facility onset. So hospital day 1 through 3, community onset. Hospital day 4 or more, hospital onset. Or healthcare facility onset. Additionally, NHSN has a calculator that can help with these determinations.
The flowchart also indicates that outpatient MDRO LabID events are categorized as community onset.
Here, this patient was admitted on the 10th and a positive CDI was collected on the 12th. This would be a community onset. An inpatient location less than or equal to 3 days after admissions to the facility is community onset. Any specimen collected after the 12th or hospital day 4 would be considered hospital onset. Community onset healthcare facility associated, which is for C. diff only, is collected from an inpatient or an outpatient location from a patient who was discharged from the facility less than or equal to 28 days prior to current date of stool specimen collection. The previous discharge must have been from an inpatient location within the same facility and therefore is not used to set the timeline for community onset healthcare facility associated. However, you do not need to calculate this on your own. NHSN will determine it for you when calculating your facility totals and when it is reported to CMS. So the totals reported for the healthcare onset may differ from the total number of positive lab results entered into NHSN. It is essential to add the specimens that will be designated as community onset as the CO rates for the CDI and Mercer help determine the risk adjustment when calculating the SIR for your facility. So when we are specifically looking for looking at the CDI LabID events, onset will be community onset healthcare facility associated if the patient has a prior discharge and was an outpatient or in a facility for 1 to 3 days. If the patient was in the facility longer, it is considered a hospital onset.
This flowchart categorizes CDI LabID events based on prior discharge status, patient location, and hospital day. The highlighted section represents one pathway within the overall decision process.
A patient was admitted and discharged on the 2nd and 4th through the 4th, and then readmitted on the 17th. And the specimen was collected on the 19th and discharged on the 21st of March. This would be considered a community onset healthcare facility associated LabID event because it was collected from an inpatient or outpatient location from a patient who was discharged from the facility less than or equal to 28 days prior to the current date of the stool specimen collection. Now let's talk about Mercer blood specimens. A Mercer LabID event is a non-duplicate unique blood source isolate. For further clarification, This is a blood isolate from the blood of a patient with no prior positive MRSA blood specimen in their particular location in the prior 14 days, even across calendar months. The day of specimen collection is considered day one for this determination. Duplicate specimens are only those positive specimens collected in 14 days of a previous positive when the specimens were collected on the same unit. If two specimens are collected from and attributable to the two different units, they must both be reported regardless of the time frame between specimen collection. Here's a flowchart to identify a MRSA bacteremia LabID event. As I said, if a patient has a prior positive MDRO isolate from that was less than or equal to 14 days from the same patient and location, it would be a duplicate MDRO test. Now, if that is not the case, it would be a LabID event. Another important factor is determining which events will be counted in your standardized infection ratio, or SIR. And as a reminder, SIRs are only available in FACYN surveillance of MRSA, bacteremia, and C. diff. In the analysis section under the MDRO CDI module, LabID event reporting, there is a section that shows you all of the MRSA LabID events. You will go to analysis, all MRSA LabID events, and then you would click on line listening for all MRSA LabID events, and then you would run the report. And here's an example of what the report looks like. You have important variables like patient ID, org ID, location, admissions date, source, specimen collection date. As well as other variables. In the last variable, it gives you a value of 1 and 0. And the value of 1 means that this event will be included in your SIR calculation. And if you have 0, it will not be included. So our first patient ending in 231. Location is the medical oncology, admitted on 5 May 30th. And as well as that's the same day as the specimen date. Or excuse me, the specimen date is June 3rd. The culture was collected on, or the stool was collected on day 5 of the mission, so it will be a healthcare onset and will be counted in your SIR. As you can see, the 1. Patient 2, on the other hand, has 0, so it will not be counted in your SIR. So let's talk about LabID events for CDI. Similar to MRSA LabID events, a CDI LabID event is a non-duplicate lab result in which there is no prior positive CDI lab result for the patient in this particular location in the prior 14 days. The day of a specimen collection is day 1 when considering this date range. For CDI, we want to remind everyone that only tests performed on unformed stool should be counted as a LabID event. Give your lab the authority to refuse specimens that don't conform to the container. And here's a quick algorithm to identify a CDI LabID event. So if the patient has a prior positive CDI test result in less than or equal to 14 days from the same patient and location, it would be considered a duplicate CDI, C.diff test and would not be an eligible ID, not a LabID event. But if the patient does not have a prior positive C.diff test in 14 days or less from the same patient and location, it would be considered a LabID event. So let's talk about incident versus recurrent. An incident CDI result is a LabID event from a specimen obtained greater than 56 days after the most recent LabID event for that patient. Excuse me. Or with no previous LabID event documented for that patient at all. A recurrent LabID event is a specimen obtained greater than 14 days but less than or equal to 56 days after the most recent LabID event for that patient. Again, NHSN calculates this for you in the analysis of your reported events. Speaking of calculations, this shows the LabID event calculator that will help you along the way of calculating LabID events. All right, let's talk about the analysis. So this is the same analysis slide that was demonstrated for MRSA, but showing all C.diff LabID events instead. This is important because only incident hospital onset count towards your SIR, and this will let you know which C.diff events are incident and count toward your SIR. You will go to analysis, all C.diff LabID events, line listing for all C.diff LabID events, and then run the report. In the CDI, this analysis shows the variable has, which is next to the last column, contains a value of 1 or 0, and it is interpreted the same way. So, like I said, in the previous slides, talking about analysis, the value of 1 means that this event will be included in your SIR calculation, and the value of 0 means it would not be included. So if you use clinical decision support software, it is best practice to compare your results monthly to a laboratory line list. As part of a validation conducted by TDH, facilities that did this comparison had significantly higher percentage of correctly reported events than facilities that validated less frequently or not at all. What we found was that at times there would be a difference between when someone was admitted to a unit and the time they arrived at the bed, which might be in the ED and admitted to an inpatient unit, but while they are still in the ED, a specimen is collected, but the clinical decision support software will show them admitted to an inpatient unit.
The chart compares facilities that validated monthly or more frequently with facilities that validated less than monthly and shows a higher percentage of correctly reported events among facilities performing monthly validation.
So let's go over frequently asked questions. These are just showing LabID events examples. So one facility is doing active AST, active surveillance testing, and LabID event reporting. If an MDRO is identified during AST, is it also a LabID event? What do you think? No. Because a LabID event is an MDRO isolate obtained for clinical decision making, not as part of routine surveillance. Question 2, true or false? At the overall facility-wide levels N for IRF, ED, and 24-hour observation, MDROs can be monitored for all specimen types or for blood specimens only. That would be true. I have a question 3. I have a patient with a positive MRSA blood specimen earlier in the month. If he has another positive blood specimen 1 week later on the same unit, do I enter a second LabID event in NHSN? Yes, you would not report an additional positive blood specimen that was obtained the following week. But if it's in a new location, you would report it. Question 4, I have a patient with a positive MRSA blood specimen late in the month. And the following month, he has another positive blood specimen. Do I enter the second specimen as a LabID event in NHSN? So you would need to apply the 14-day rule to determine if the specimen meets the LabID event definition. Remember that the 14-day rule crosses months. All right, let's go over MDRO test result algorithms for all specimens laboratory identified events. So we have an MDRO isolate from any specimen per patient and location. It's the first in the calendar month per patient per location per MDRO. If it is positive, it would be a LabID event. If their MDRO isolate is positive, and it's the first in the calendar month per patient per location, as we discussed in the previous slides, it would be a LabID event. Now, if that's not the case, and it has multiple it's multiple isolates within or equal to less than 14 days, it would be a duplicate MDRO isolate and not a LabID event. If the source is not the blood, if the source is not blood for the patient, it would not be a LabID event. But if it is, so that's when you would check for the prior same MDRO from blood in the 14 days or less from the same location. So if that is the case, it would not be a LabID event. And if you have a prior same MDRO from blood in 14 days or less from the same location, if that's not the case, it would be a LabID event.
This flowchart outlines the process for determining whether the MDRO isolate qualifies as a LabID event. The process evaluates whether the isolate is the first in the calendar month, whether the specimen source is blood, and whether a prior positive blood isolate occurred within 14 days before determining the final outcome.
Question 6, a MRSA positive blood culture was obtained in the ED and then admitted to an inpatient unit on the same day. How do I report this LabID event? Report this MRSA blood specimen as a LabID event for the ED. If the patient went to an affiliated outpatient clinic, how would it have been reported? It would have been reported for the inpatient location. Remember, not 24 hours must be the same calendar day. If the specimen collected at 11 p.m. and the patient admitted at 1 a.m. the next day, another note is if the specimen was collected at another affiliated outpatient location on the same calendar day as inpatient admissions, you will need to enter it as a LabID event for the admitting location. Question 7. A MRSA positive blood culture was obtained while a patient was in dedicated out of observation unit and then was admitted as an inpatient the same day. How do I report this LabID event? You report this MRSA blood specimen as a LabID event for the dedicated observation unit. An observation patient is placed on an inpatient unit, and MRSA plus blood cultures are collected. How do I report this LabID event? It would have been reported for the inpatient location. And as we wrap it up, wrap this webinar up, here are resources that you can use. If you have any other questions, you can email the HAI inbox. And we have upcoming webinars. The next one will be Monday, February 10th at 1 p.m. All right, and my last slide is upcoming trainings. Like I said previously, there will be case-based trainings in March. So register for case-based trainings will occur later via TNC Train, and you will be able to get CEUs. Thanks everybody for attending this webinar. Now I hope you all have a great rest of your day. Any questions?